Good evening, Dr. Ahmed. You can hear me?
Yes, Doctor.
Yes. Until now, we have 12 delegates. So we will wait another 1 or 2 minutes, then we will start our last day of the course. So good evening again. I am Dr. Gültekin Bakirova. Today our last day for course, and we have today following program. So remaining 3 presentations. First presentation by Dr. Wagas Mahmoud is consultant ICU. He will present a pathological approach to management of COVID-19. And the second presentation will be by Dr. Saima. She's consultant ICU. She will present CPR dynamics in COVID-19. And the third and last presentation by Dr. Walid. He will present lecture with videos of airway management in ICU and in general, as well as consideration in COVID-19. And after these 3 presentations, there will be last session MCQ, and we will announce in the group, WhatsApp group, how to proceed for MCQs, and MCQs contains of 40 questions, single best answer. We will give you 40 minutes and we will instruct how to use the link. So first lecture right now will be presented by Dr. Wagas Mahmoud, consultant ICU. Welcome, Dr. Wagas, and you can start your presentation.
Assalamu alaikum, everybody. Thank you, Dr. Gültekin. I think some issue. Just wait a second. Can you see my screen or no?
No, not yet, Dr. Wagas. It's not appearing.
I think now apparent or no?
Yes, now we can see screen.
Okay.
Just enlarge it, please.
Yes. Okay, Bismillahirrahmanirrahim. Today we will discuss about the pathophysiological approach for the management of COVID-19. So in this slide, we can see this COVID-19, it interacts with the S2 receptors and get it entry into the cells and replicates, and finally it will cause the downregulation of the S2 receptors. So this is actually the mechanism. What is going on inside the body actually, angiotensinogen is acted upon by renin and converts to angiotensin 1. Then ACE1 acts on this and converts to angiotensinogen 2. This angiotensinogen 2 acts on ACE2 receptors and converts itself into a good product, which is byproducts from angiotensin 1 to 7. And it has very good effect on body like vasodilatation, anti-apoptotic effect, anti-fibrotic effect, anti-proliferative effect. So all these effects will lead to decrease in blood pressure, decrease cardiac fibrosis, and decrease thrombosis, and decrease ARDS. So what actually happens when the COVID-19 acts on these receptors, as I told in this slide, ACE2 receptors, what happens? It causes down regulation. So what will happen? Angiotensin 2 will not be converted into good product, that is angiotensin 1 to 7, but actually it is converted more to the angiotensin 1 and acts on the angiotensin 1 receptors, and it causes just opposite effect of that, that is vasoconstriction, inflammation, fibrosis, and proliferation, which will lead to the side effects like hypertension, cardiac fibrosis increment, increase in thrombotic events, and ARDS. So this is the way the COVID-19 affects the ACE2 receptors and cause the problems in the body. ACE2 receptors are found in the brain, in the lungs, in the intestines, and in the testicular tissue. So the COVID-19 affects these tissues mainly. The course of the disease, it can take three paths. The first one, the patient with initially present with severe hypoxemia and severe breathlessness leading to immediate intubation. The patient can present either moderate to severe hypoxemia, but only moderate work of breathing, and he passes through this course and gets healthy recovery. And the third pathway is the biphasic, where the patient first takes the indolent course with a moderate work of breathing. After 5 to 7 days, suddenly deteriorates and goes into hypoxemia, breathlessness, and with bilateral infiltrates, consolidations, and finally intubated and ARDS. And we can see the minimal changes and the ARDS like picture, the worst picture in the COVID-19 to the mild infiltrates in the X-ray. The other three presentations could be like there can be COVID-19 can present as a consolidation, it can present as ground glass opacities in the lungs, and it can also cause the mediastinal lymphadenopathy. Here we can see. Okay, this gentleman, Getty Noni, and is a German anesthetist, and with his colleagues, he presented the theory that we are managing the ARDS of COVID-19 in a wrong way, and we are treating COVID-19 as a typical ARDS, which is not the case. And he presented his findings in Metric Thoracics of General, and saying that COVID-19 is not always a typical ARDS. So we'll go in depth of that, of his theory. So he said that the factors which are modifying the disease pattern can be of such type. For example, the severity of the grade of infection can affect the disease pattern, how the affected person responds to the disease, and what are the physiological reserves he is having, how much immunity he is having to fight with this disease, and what are the comorbidities like hypertension, ischemic heart disease, heart failure, and organ transplant issues are like this comorbidities. It can affect the disease pattern also. Second, once the patient is on ventilator, how his lungs respond to the ventilator, or how a ventilator and lung interaction, it will affect the disease pattern also. And he said also that the time of presentation is very important, that how late the patient presented to us or in the hospital, it will affect, of course, the disease pattern. So all these factors were summarized by Massachusetts General Hospital, and they said we can divide these factors into epidemiological, vital signs wise, or labs wise. So they made a score like this. For example, if age is more than 65, patient is having already lung disease before, or having kidney disease before, diabetic with uncontrolled hemoglobin A1C more than 7.6, with the history of hypertension, history of cardiovascular disease, with obesity, BMI of more than 30, our patient is on monoclonal antibodies for other treatment like rheumatoid arthritis treatment and like this, or patient has undergone any other transplant and immunosuppressive therapy, or patient is already immunocompromised with HIV and CD4 count less than 200. These factors are very important. If one of the epidemiological factor plus one of the vital signs problem or the lab problem, then patient has high risk of progression to the severe disease. So what were the vital signs they mentioned in the chart? That their respiratory rate more than 24, heart rate more than 125, saturation less than 93, and PF ratio less than 300. And labs wise, if D dimer is more than 1000 or 1, CK more than twice upper limit of normal, CRP more than 100, elevated troponin, ferritin more than 500, and of course lymphocyte count less than 0.8, and LDH more than 245. So one of the epidemiological factors plus one of the vital sign abnormality, or one of the epidemiological factor plus one of the labs abnormality, that the patient has high propensity for worsening of the disease. So as I mentioned earlier, that the ACE2 receptors are found in the lungs and brain. So in the lungs, they found that there is high perfusion and low ventilation. So VQ ratio will be disturbed. And once there are microthrombi, the area of exchange of gases will be reduced to increase that space, and there will be shunting, and finally because of collapse and ARDS. The other ACE2 receptors presence on the brain, COVID-19 will cause anosmia. Patient can be delirious. He can have the problems in cognition. Even if involves the respiratory center in the midbrain, like this, patient can have cardiorespiratory arrest even. So this slide is very important because it explains, as I mentioned, that high perfusion but low ventilation. So the VQ ratio is imbalance. What will happen? It will cause the hypoxemia. To cover up this hypoxemia, patient will try to take deep breaths, and once to take deep breath, the tidal volume will increase for the patient himself, and this will lead to the patient self-induced lung injury. Second, once this brain activation of these receptors will cause increased respiratory drive in the midbrain. So it will again lead to the same cycle. Increase, there will be hypoxemia, increased work of breathing, increased tidal volume, and this will lead to the patient self-induced lung injury. The third pathway, if patient develops sepsis, also pneumonia or like this, what will happen? It will cause increased metabolism, and same work of breathing increased tidal volume, patient self-induced lung injury. And COVID-19 itself can cause acute lung injury, direct injury to the lung. So this combination of patient self-induced lung injury along with direct effect of the virus will cause acute lung injury. So it leads to the ARDS-like pictures in the lungs. This phenomena of patient self-induced lung injury was described earlier by Barak in 1938 and Maccheroni in 1988, and it published in different reputable journals also. So the factors which I described earlier, the interaction among them, and finally when the time passes, the disease pattern can be divided into two phenotypes. One is the H. H stands for high, everything high, and L stands for low, everything low. So what is high, what is low, we'll discuss further. But these interactions and factors interaction with passage of time will cause into the two spectrum of disease in the COVID-19 affected lung. It can be L type, it can be H type, H for high, L for low. So what happens actually once hypoxemia, there will be dysregulation of the perfusion. So it will cause either two type of pattern of diseases. What is L? The patient lung can have low elastance, low VQ, low recruitability, and limited peak response. If this type of lung after affected by COVID-19 will cause phenotype L. And for example, now this pulmonary microthrombi and come into action and lead to the pulmonary edema or the heavy lung or wet lung, then we will have a lung with high lung elastance, high recruitability, high right to left shunt, and high beep response. Then this phenotype will be H. So L type can be converted with passage of time to the H type. So this was the concept by Gatinino. So that's why he said that this is typical ARDS picture of any lung, and this is atypical. So he says that we should not treat every ARDS and COVID-19 as a typical ARDS, but it can be atypical, where the lung is having low elastance, low VOQ, low recruitability, and limited beat response. So if we continue managing on this basis, like H type every ARDS in a typical way, we are actually damaging the lung. So this is the cycle which showed actually what happens lung injury, then impaired gas exchange, lung elastance, increased respiratory drive. So once increased respiratory drive, increased tidal volume by the patient, it will lead to the self-induced lung injury, and that will be increased esophageal pressure swings with increased tracheal pressure, will lead to the capillary leak. So once leak is there, the lung will be wet and lung edema. So we can see initially, which was the dry lung is converted to the wet lung. The L-type lung is converted to the H-type lung. So this cycle goes on and further deterioration if we are not managing the ventilator settings in a proper way. They also presented in their article one case. We can see here one lung which has good aerated tissues and only a few patches of consolidations and pneumonia, and PF ratio was 95 at that time. Later on, within 7 days, the same patient and the CT repeated, and we can say very less areas of aeration are there, and most of the lungs is destroyed. And PF ratio it didn't change much from 95 to 84. So this dry lung is converted to the wet lung now. So what they did actually, they given the patient on 15 liter of oxygen, and if the patient was managing saturation more than 95, they considered it mild. If it's not maintaining saturation 95, they considered it moderate to severe. For mild cases, they kept managing the patient with either with the high flow nasal cannula or with the CPAP or BiPAP, or otherwise they were intubating the patient. So the other way of measuring the work of breathing, we can do the measure the work of breathing or classification. We can check through the central venous line, which is inserted into subclavian vein, and you can see the change in the central venous pressure in aspiration and expiration. And if this swing in the inspiration expiration is less than 10 centimeter, and in those patients they used high flow nasal cannula or CPAP. If it was more than 15, these swings, they intubated the patient. So they use this central venous pressure as a guide for the work of breathing. But clinically, you can measure, and also there's another way, either esophageal manometry, you can check the pressure and then calculate the work of breathing. The easiest way is the central venous pressure swings during inspiration and expiration, and they used this in this study. And I'm refraining from my topic a little just to refresh. This was the method adopted by Gattinoni and his colleagues. But in King Saud Medical City, we have a different protocol. So we'll try to avoid this non-invasive positive pressure ventilation unless these are the exceptions. Short-term bridge to ventilator availability. If ventilator is not available immediately, then we can use this non-invasive positive pressure ventilation, CPAP, BiPAP, or high flow nasal cannula, which is available now, or rapidly reversible cause of hypoxemia. For example, patient going into acute flash pulmonary edema, or there's mucus plug, and or small aspiration is noticed. Or of course, obstructive sleep apnea or tracheomalacia. There we can use these modalities. And of course, if we're using BiPAP machine, it should be with dual limb with HEPA filter, and should be strict airborne precautions, including N95, strict isolation, and active pressure room. and ensure mask devices fit well and there is minimal leak. The same thing is, for example, if patient is deteriorating, then of course we'll go for intubation. These are the general indications for intubation, such as NON-90, FiO2 more than 0.4 and with increased work of breathing. Rapid progression of COVID-19 disease by clinically estimated by the physician, or pH less than 1.3, PCO2 more than 50 or above, hemodynamic instability, mercury organ failure, will intubate the patient, will not keep the patient waiting on the non-invasive first pressure ventilation or high flow nasal cannula. So we come back to the topic, and we have reached that patient once he is not maintaining on non-invasive first pressure ventilation or nasal cannula, or directly he was having the height swings in the central venous pressure more than 15, intubate the patient. And what they did, what were their targets? They wanted the saturation 1994 with PO2 of around you can say around 60, PCO2 of 45, and plateau pressure of less than 28. So what they did, intubation, and patient were mechanically ventilated. And initially they kept the target volume 8 ml per kg, PEEP of 8, and the respiratory rate to adjust the end-tidal CO2 around 35. So the other way, they measured the driving pressure. So driving pressure is equal to plateau pressure with the minus P. PEEP is apparent, and the plateau pressure is the end. At the end of inspiration, we hold the breathing for about 1 second and measure it. So this value should be less than 15. If it is less than 15, over targets achieved, we'll continue the same 8 ml per kg body weight of this target value. If not, then we can reduce the target volume to 6 ml per kg body weight. Now, once if target saturation is less than 90, in spite of this modifications in the ventilator settings, and FiO2 is not reaching, and FiO2 requirement is more than 0.7 or 70%, then we can use neuromuscular blockade. Increase the PEEP in 2 centimeter of gradually. For example, we started with the PEEP of let's say 8, then we go for 10, 12 until we reach the 15 centimeter of water. And these are our targets again. If we don't achieve these targets, and if we achieve this target, it's okay. If we don't achieve, for example, saturation still with this neuromuscular blockade and increment of PEEP till 15 centimeter water, and saturation is not touching more than 90, and FiO2 more than 0.7 now required, or more than 70% required, then we'll check the compliance of the lung. So compliance of the lung, if more than 40, it means your lung is compliant and it does not need high PEEP. So this type of lung where not compliance not required in higher value or more than 40, we'll consider is L-type phenotype of the COVID-19. And this is needs low recruitability, tidal volume of 8 ml per kg, we should keep it, and PEEP should be moderate, 8 to 10, not to increase more than this. This is atypical to the ARDS protocol, which is a typical ARDS in pneumonia cases. Here, PEEP should be increased according to the increment in the FiO2 in the ARDS protocol. But if compliance is more than 40, it means your lung is compliant, does not need high PEEP. So PEEP should be kept 8 to 10, tidal volume a little bit higher of ARDS protocol, 8 ml per kg, and this is considered as L-type. If patient compliance is not more than 40, it means non-compliant lung, and we can give the high PEEP in this type of lung. That's why it's called H-type. Now phenotype H, high elastance, high recruitability, prone responsive, and high PEEP is required, and we can use the APRP mode. So this is the way we are managing the L-type differently from the H-type based on compliance. So this was the concept of getting NON-I. So next step is hypoxemia in spite of this adjusting the ventilator according to L-type or H-type. If still there is hypoxemia and to the prone position is not effective, and APRB more than 6 hours, and what will happen? So we discuss with the ECMO consultant. We put the patient on ECMO, or if he is not a candidate for ECMO, then we should discuss with the family and among our colleagues regarding the code status of the patient, DNR or not to be DNR. So, so in summary, this can be 3 patterns for disease: hyperacute, indolent, and biphasic. And CPAP or non-invasive ventilation can be used. Be aware of the biphasic course, and don't treat every ARDS in COVID-19 as typical ARDS, but can be L-type phenotype, which needs low PEEP and relatively higher tidal volume. Thank you very much.
Thank you, Dr. Abbas. If anyone have question, please post in the chat group. Okay, I think there is no questions. Thank you, Dr. Wagasbe.
Thank you very much.
Next presentation by Dr. Saima. She's ICU consultant and she will present the CPR dynamics and its consideration in COVID-19. Welcome, Dr. Saima. Can you share your screen, please? Your presentation. You can start your presentation, please.
Good evening, all. Thank you, Dr. Gultaki. I hope all are enjoying this concise course. By now, must be having a clear idea about the COVID-19 diagnosis and management. Today, my talk is about the CPR dynamics in COVID-19. So, as you all know, by the end of this lecture, my objective will be to clearly go through the basic life support guidelines which are endorsed by American Heart Association. And I will try that you are able to understand the importance of team dynamics, including the roles of the team leader as well as the team members. And then we'll move to the specific precautions and the guidelines regarding the CPR in the COVID-19 patients. Ahmed, can we go next? All of you must be aware, this is a very common slide and very important slide. Yes, I'm going to talk about the chain of survival. And these are internationally recognized standards of early interventions, which gives the victim of sudden cardiac arrest the best chances of survival when we implement it quickly. So basically, these are the 5 events that must be occurring rapidly in an integrated manner during the cardiac arrest, which consists of early recognition and initiation of help, early and immediate high quality CPR, rapid defibrillation, and advanced life support, followed by the post-resuscitation care. So all of these are interdependent links in the chain of survival. So now, as we are talking about the high quality CPR, I will like to go and emphasize on the 5 important components of the high quality CPR as endorsed by the American Heart Association. Next, please. Once we say high quality CPR, we are talking about push hard and push fast. So fast at a rate of 100 to 120 compressions per minute, allowing for a depth of at least more than 5 centimeters, which is approximate 1/3 of anterior posterior diameter of the chest, with full chest recoil in between, and minimal interruptions in between the compressions and adequate ventilation. Here also very important is that if we don't forget to rotate the compressor every 2 minutes, or if early if he is fatigued. Next. As we all know, the teamwork, it makes the dream work. And basically, a successful team is a group of many hands and one mind. And they are not only having medical expertise and the mastery of resuscitation skill, but they also demonstrate effective communication and team dynamics. Next. Next. As we know, whenever there will be a code blue in ICU, you will be the first responder. So you will be the team leader till another component of the team will come and take over. So I would like to emphasize here the role of the good team leader. As we know, the team leader should have the good situational awareness, like paying the attention to whatever is going on around and is not only fixing to one problem at a time. So as a team leader, what we expect, a good leader, an effective leader should have good organization, should organize the group, should monitor the individual performances of the team members, is a backup for the team members, and is a model of the excellent team behavior. Also is involved in the training and the coaching as well as facilitate the understanding. As we know, the members of the team, if we are the member, we must respect this authority of the team leader, and we should be ready to carry out the instructions by him. As we all know, the poor leadership always introduces frustration, anxiety. It also have a negative impact on the team as well as its future performance. Next. While we know the team leader is focusing on the comprehensive patient care, as a member of the team, we must be ready to focus on the individual tasks. And these tasks will be endorsed to us by the team leader. So the team member, as a team member, we must be clear about our role, responsibilities, and assignments, as well as we must be well practiced in the resuscitation skill. We are knowledgeable about the algorithms, and for sure committed to success as a team. Once we talk about the team dynamics, these are basically the operating forces within the team. Next. To have the effective team dynamics, we must have some characteristics which are common to all the team members. These include the closed loop communication, clear messages, clear roles and responsibilities, knowing one's limitations, knowledge sharing, constructive interventions, as well as re-evaluation, summarizing, and showing the mutual respect to each other. Next. So if we say about communication, it is very clear that the communication is an essential component of any team dynamics, particularly in the times of high stress. And once we talk about communication, we mean effective communication. And once we talk about effective communication, we mean closed loop communication. Next. So whenever what we mean by the closed loop communication, basically like a team leader will ask for a procedure by the team member by asking the name, and the member will reconfirm from the team leader, will do the procedure and will acknowledge back to the team leader. So it is like closing the loop. It is very important because it reduces the errors. It is also removing the ambiguity. It allows for the questions if the instructions were not clear or were not heard properly. And it is a very important component of the effective team dynamics. Next. We cannot overemphasize the role of the clear messages. So once we are the team leader, what we require is that we should deliver the messages in a controlled tone of voice, which are very clear, uh, in a calm and direct manner without yelling, shouting. And because unclear communication for sure will lead to delay in the treatment or to the medication errors. Like suppose if you want to give adrenaline and you can ask by naming the staff, I give adrenaline. It's not a clear message. Rather you will say, Asma, give adrenaline 1:10,000, 1 milligram IV push. And she may reply back, adrenaline 1 milligram IV push given. So this is an example of not only clear messages, but also the closed loop communication. Next. Similarly, as a leader, we must depute the role for all the team members at the beginning of the cardiac arrest, because it's very important. As unclear roles, they will lead to multiple members performing the same task again and again, missing the essential task, and there will be the freelancing of the team members, and it will lead to inefficient performance of the team. To avoid this inefficiency, the team leader must delegate the task. If he is unsure about the responsibilities, he should not assign. But if the team leader wants to give additional responsibilities to any member of the team, here again, he must communicate with the team members before deputing some additional or extra role for the team members. Next. So as we know already, for an effective team dynamics, the minimum number of the people who should be attending the cardiac arrest is 6, including the team leader. So the team leader will be there. One is responsible for the airway and breathing. One will be responsible for the compressions, and the other will take over the role of defibrillation along with the compression, alternating with the first compressor. And one of the nurses can be responsible for the vascular access as well as medication, and one will be responsible for the documentation. Ahmed, next, please. So as we are talking about the COVID-19, here the changes are implemented as endorsed by American Heart Association, European Council, as well as the Resuscitation Council of UK. All they are emphasizing on limiting the number of people who are attending the cardiac arrest to the minimum which are required for either carrying out the procedure or for the essential patient care. So it can be reduced to as low as 4 members of the team who are present at the time of cardiac arrest. Next. So here, as I told before, these are the important components of team dynamics. As we are short of time, I will not go into much detail of each of these, but only one thing here I will like to just highlight: the fixation error and knowledge sharing is very important. Like if the team leader becomes stuck with one of the uh, treatment modalities or investigation modality, and
Hello,
his mind
Dr.
will not.
Ahmed, you can hear me?
Hello.
Dr. Ahmed?
اوكي يستخدم يلا عشان
Am I clear,
you can yeah, you
Dr.
can
Gultan? Can you hear me?
yes continue Dr.
Okay. So here it is very important that this is known as fixation error. So how to solve the fixation error? As a team leader, we must discuss the situation with all the members of the team. This is known as knowledge sharing. So to discuss the causes of the cardiac arrest, what could be the possibilities, what could be like reversible H's and T's, what can be offered further for the patient. So whenever we have fixation error, the answer is knowledge sharing. So we must have confidence upon our team members. We must allow them to speak up, and we should allow to listen to their suggestions, and it may help us to solve the problem. So next slide, please. As we all know, due to this COVID-19 pandemic, there were interim guidelines which were released, particularly regarding the cardiac arrest and the care of these patients who are confirmed or suspected COVID-19. And the most precise and comprehensive guidelines were released by Resuscitation Council of UK on 27th of March. It was followed by American Heart Association also, more or less the same. But really, these are very nice. Although it looks very busy slide, I would like to make it easy for you. If you concentrate on the slide on the left, there are mentioned phases: phase 1, phase 2, phase 3. The beauty of this guideline is that it is not only giving us the clues what to do next in the case of cardiac arrest for such patient, but also is giving us a guidance on what level of PPE which we should be wearing at the time of arrest. Like those, all of you by now, you know that chest compression, any airway interventions, these are aerosol generating procedures. So for aerosol generating procedures, you have to go with the level 3 PPE, which consists of disposable glove, gown, and filtering face piece, respirator. Disposable eye protection should be there. So until unless you are in your level 3 PPE, you cannot initiate chest compressions and you cannot do airway interventions. That's clear. So here the phase 1, it is consisting of discussions, decision making, and conversations regarding the treatment escalation and emergency management of these patients. So this is very important. So there is a great emphasis on decision making and to decide the core status of the patient early. Why? The safety of the healthcare worker is the priority in all the guidelines, not even in this pandemic, even before this pandemic, all the guidelines, they are focusing on the safety of the healthcare worker in order to avoid unprotected exposure to any unanticipated cardiac arrest. So if you decide the patient is not for the active code, patient can move to the pathway of end of life care and can be given the care according to the institutional policy. But if the patient is active code, you have to assess for the responsiveness or the breathing pattern. If patient is not breathing normally or is unresponsive, you will activate for the help, and you will for sure you have to state the COVID-19 status for the patient. Again, it is very important. So the team who will come to help during the cardiac arrest, they will be having the appropriate level of PPE before they approach the patient. Meanwhile, we can assess the rhythm if it is a shockable or a non-shockable rhythm. If a shockable rhythm, which include the VF, pulseless VT, we can give the shock for the patient. And we can continue to shock at least 3 shock maximum till the help arrives and we can resume the chest compressions. So here again, it is clear without level 3 PP, no chest compression for the patient. If it was a non-shockable rhythm like PEA, asystole, you have to either go and do the proper PPE or wait for the help before any compression can be given. The rest is the same for like we have all the ACLS algorithm, like during the CPR, you have to make sure high quality resuscitation, minimal interruption, look for the reversible causes, and tidal CO2 monitoring can be done in these patients. Along with that, immediate post cardiac arrest treatment should be applied for all with a target of saturation for 94 to 98 normal CO2. You have to ask for the 12 lead ECG. You can ask for the blood gas, look for the precipitating causes, targeted temperature management can be applied. And there are some specific consideration for these patients, like using the ultrasound imaging, mechanical compression devices, if these are available in the department, they can be used, or transfer to higher facility for coronary angiography or percutaneous intervention if needed, and even the consideration for the extracorporeal CPR if it is available. Next. So again, the resuscitation for COVID-19 patient in hospital, we have to consider treatment escalation and resuscitation decision for all the inpatients. This is the most important message which I will like to deliver through this lecture. So we have to recognize the arrest. You palpate only the carotid pulse. Do not put your face near the patient face to listen or feel for the breath. Call for the help. State the COVID risk and attach the defibrillator, shock if indicated. So why shock? Here I have seen there is a great emphasis on early defibrillation. And we believe that it is the most vital link, but it is the weakest implemented link in the chain of survival. And we know that 50 to 70% of sudden cardiac arrest patient, if they receive the defibrillation early within first 5 minutes of arrest, the survival is about 50 to 70%. So for every minute that passes, there is a 10% less chances of survival. So, and also the defibrillation, it is not an aerosol generating procedure. It can be done even with the level 2 PPE. That's why I believe there is a great emphasis on defibrillation for these patients. Next. So once you are in level 3 PPE, you will proceed for airway interventions as well as chest compressions. If patient is not intubated, you will leave the face mask on the patient face for oxygen and do the compression only CPR. Restrict the number of the staff who are available at the time of CPR, and secure the airway by the most experienced and the most competent member of the team. Again, here why? To decrease the aerosol formation, to decrease the number of attempts which are taken. And it is advised if you have video laryngoscope available, ideally we should use it. And once the patient is able to be connected to the ventilator, avoid the discontinuation of the closed circuit and make sure to use the HEPA filter or viral filter. Next. And we have to identify the reversible causes, as I already told. So you must be aware about all the reversible H and the T's. H referring to hypovolemia, hypoxemia, hyperkalemia, acidosis, and hypothermia. while the T's, they refer to tension, pneumothorax, cardiac tamponade, acute MI, thrombosis like massive P, and toxins. And so these are the basics of the ACLS, like we are doing for all the patients. And you have to dispose of or clean all the equipment used during the CPR. This is important, as well as to remove the PPE safely, avoid self-contamination, dispose in the specific clinical waste bags, and perform the hand hygiene. And post-resuscitation debriefing is very, very important to help improve the performance in the next any code blue if you face during your rotations. So basically the general principle for resuscitation in case of suspected confirmed COVID-19, these are three. So you have to reduce the provider exposure to COVID-19. You have to prioritize oxygenation and ventilation strategies with the low aerosolization risk. And you have to consider the appropriateness of starting and continuing the resuscitation. Next. So must we say to reduce the exposure because we have to save the frontliners. And these are very important steps. You have always been appropriate PPE before entering the room, limit the number of the people to those who are essential present at the time of the arrest, always keep the door closed to prevent the airborne contamination of adjacent door, use the mechanical compression devices if available. You have to be proactive in the movement of those who are who are at the risk of sudden cardiac arrest or sudden deterioration, to prioritize them to bring to the negative airway pressure rooms in order to avoid unexpected, unprotected CPR, to decrease the risk for the healthcare workers. And whenever you announce the cardiac arrest, always announce the status of COVID status for the patient. For oxygenation and ventilation strategies, if patient is already intubated, leave the patient on vent. Make sure there is a HEPA filter attached. You have to maintain a closed circuit. Avoid unnecessary unnecessary discontinuation of the closed circuit to reduce aerosolization. You have to increase the FiO2 to 100%. Keep the access control mode. Maintain the tidal volume 6 ml per kg with the rate of 10 breaths per minute in order to avoid overventilation, and adjust the trigger to off. If intubation will be delayed, what you have to do, you can keep the oxygen with a non-rebreather face mask to allow passive oxygenation, and you can continue with the compression only CPR. Manual ventilation with a bag valve mask is very controversial, particularly if a consultant who is leading the CPR wants to go for a bag valve mask ventilation. It can be considered in specific situations. If it is still considered delay in intubation, you can go for LMA. Do not forget to attach the HEPA filter. Next. As we discussed just now. Next. So this is the last slide, and I will say this is the take-home message. The conversations, decision making for treatment escalation, and the planning, it must be individualized, it must be prioritized, and should be discussed between the teams, and should be well communicated and well documented. Again, the safety of the healthcare worker. So any patient who is not for active CPR, it should be documented well. And early identification of those patients who are suspected or confirmed COVID-19, who are at the risk of acute deterioration or sudden cardiac arrest, to prioritize them to bring to the dedicated area with adequate expertise like critical care, having all negative pressure rooms, having all the equipments and the expertise with appropriate PPE available to avoid unexpected cardiac arrest, again to protect the healthcare workers. Thank you. So if you have any questions, I will be happy to answer. I think we don't have any questions.
Actually, there is no question until now.
I will be still online. They can leave in the chat room.
Okay, thank you, Dr. Simon, for your informative lecture.
Yeah, thank you. Thanks for listening.
Okay, so now we will go to the next speaker, Dr. Walid. He's our ICU assistant consultant. He's the head of quality in our ICU, and he's our instructor for the airway management. Dr. Walid, he will discuss about airway management in the COVID-19.
Thank you very much, Dr. Ahmed.
Welcome, Dr. Walid. But please focus with him. You will enjoy with his lecture.
I hope to be able to continue it and not run into technical problems like the previous time. And Dr. Ahmed, I have my phone beside me. If at any time I get interrupted, please give me a call.
No problem, it's okay.
Okay. So good evening, everyone. This is a brief talk about airway management, and we try to tailor it to COVID. My name is Walid Al-Itrebi. I'm an ICU assistant consultant with a background of anesthesia. At the beginning, I have nothing to disclose, and I claim no rights to any of the videos I'm going to play in my presentation. So when we talk about airway management, I just want you to focus on only one thing. We need the pathway from the nostril or the mouth till the beginning of the respiratory tract, that's the larynx, to be open. That's all I care about. I'm only concerned with keeping this pathway open. We're not discussing what we are giving from outside, be it oxygen, anesthetic gas, whatever, because if the pathway is obstructed, the patient is not going to benefit. We're going to take it from the least complex to the more complex, but just keep in mind that this doesn't happen in reality. In reality, we approach the patient with the method that we believe is the most suitable. So the first method I think we are all familiar with, we learned it in BLS. It's called jaw thrust. In jaw thrust, you place your fingers, the index and the middle, at the bony angle of the lower mandible and push the jaw upwards or thrust the jaw upwards. You sometimes assist with your thumbs. And just this simple maneuver sometimes displaces the tongue from the pharyngeal wall and opens the airway. I just want to emphasize that you always put your fingers on the bone, never the soft tissue. If you press on the soft tissue, you're actually obstructing the airway. A similar method also we learn in BLS is called head tilt, chin lift. Head tilt, chin lift. In this way, you use both your hands to tilt the head with one hand, and again on the bone of the lower mandible, lifting the chin upwards. As you can see, the tongue is obstructing the airway by pressing on the posterior pharyngeal wall. Just by lifting the chin upwards, you displace it and open the airway. Now, there's no difference between these two methods in maintaining an airway open, except that in the head tilt chin lift method, there is an extension of the neck. And so this method is to be completely avoided if you suspect injury of the cervical spine. And by default, any trauma, you suspect injury of the cervical spine, so avoid it and use jaw thrust instead. If this is not successful, then we might move on to something we call the oropharyngeal airway. I'm sure you have all seen it before. The oropharyngeal airway, if you hold it in your hand, it's made of hard plastic. And the reason for that is that it goes through the mouth. When the patient bites or closes his mouth, he's not able to obstruct it. It comes in different sizes. Different sizes fit different patients, and every size is color-coded. But we do not have to memorize which color stands or suits which patient, because we follow a rough method, a rough technique that tells you if this oropharyngeal airway suits your patient. Just put it at the level of the mouth, and the tip should be at the angle of the lower mandible. Less than that, it is too short and it will not open the airway. More than that, it is too long and it's going to irritate the larynx. When we insert an oropharyngeal airway, although it has a C-shaped curvature following the natural anatomy of the airway, we insert it the other way around, in the opposite direction. And the reason for that is that we want to avoid the tongue. So you insert it in the opposite direction until you touch the hard palate, then you start rotating and pressing downwards. This short clip shows you the technique.
The angle of the patient's jaw. So I'm going to place the end of the OPA against the angle of the patient's jaw and have a look at the angle across where the patient's incisors are. So we're going for the level of the patient's incisors, which looks to be around about the right level for this size OPA and this patient. We then need to have a think about inserting the OPA. So to do that, we're going to invert it. So essentially turn it upside down and insert it into the patient's mouth against their hard palate, rotate it around, and then locate it into the airway, nicely into the oropharynx. So we're going to invert, insert, rotate, and locate. And that should give us a nice secure airway all the way through without the tongue flopping back against the soft palate at the back of the mouth.
So this was the simple technique of insertion. I will not take a long time discussing indication, contraindication, drawbacks, and side effects, but I just want you to remember only one thing. An absolute contraindication of oropharyngeal airway is intact gag reflex. If your patient still has some level of consciousness with an intact gag reflex, don't think of the oropharyngeal airway. It's only going to induce coughing and fighting and resisting, and even sometimes laryngeal spasm, where you have the vocal cords shut down and close the entrance to the larynx. So the absolute contraindication here is intact gag reflex. If the oropharyngeal airway is not helpful, we move to another airway, which is the nasopharyngeal airway. And from the name, this one goes through the nose and it ends in the pharynx, nasopharyngeal. If you hold it in your hand, you will notice immediately the difference in structure. It is made of very soft rubber. You can bend it, you can twist it. And the reason we were able to make it of soft rubber is that it goes through the nose. It avoids the mouth completely. So even if the patient closes his mouth, he will not be able to obstruct it. And again, we do not have to memorize the sizes fits which patient, because we use this rough technique to identify the proper size. This time, starting at the nose, the tip of the nasopharyngeal should end at the ear lobule. Less than that is too short, more than that is too long. This is how a nasopharyngeal looks in place. As you can see, going through the nose, above the hard palate and soft palate, ending in the pharynx. So if the patient closes his mouth, he will not be able to obstruct it. That's why we could make it of soft rubber and avoid the hardness of the oropharyngeal airway. The insertion here follows the natural anatomy because we don't have the tongue in our way to avoid.
We're going to face that towards the patient's septum. So in this case, if we go into the right nostril, facing the bevel towards the septum, and we're essentially just going to push it vertically down into the patient's airway, allowing it to follow the anatomical curve of the airway round to end up at the bottom of the nasopharynx. You can insert it into either nostril, and it's normally going to be into whichever nostril happens to be largest.
So the insertion technique was very simple. Ideally, the bevel should be directed toward the nasal septum, but if the other nostril is wider, then choose the wider nostril. Just like the oropharyngeal had an absolute contraindication of intact gag reflex, here also there is an absolute contraindication for actually not only in the nasopharyngeal, for anything going through the nose, nasopharyngeal, nasogastric, nasal intubation, which is a fracture base of the skull. If you have fracture base of the skull, then avoid inserting anything through the nose because it might end up in the brain. This picture was taken from a video. This is a famous American RT who has a lot of demonstration videos on YouTube. As you can see here, he's inserting a nasopharyngeal for himself. So this tells you that it is very well tolerated even by completely conscious patients. This overcomes the problem of the gag reflex with the oropharyngeal. So if the patient still has an intact gag reflex, avoid the oropharyngeal and use the nasopharyngeal instead. Next, if we are still not successful, we are still going to use an airway. So this device is actually just another airway, although it looks a little bit more complex. The structure of this airway is simply made of an elliptical shaped balloon. This is the patient's end. This part faces the larynx or masks the larynx, and that is why this is called laryngeal mask airway. So the elliptical shaped balloon is masking or facing the larynx. There is the shaft. This is your end or the operator's end. It has what we call a universal connector. This means it connects to an ambu bag, a ventilator, an anesthesia machine. It connects to all the types of devices. Now, this elliptical shaped balloon is inflated with air to create a seal using this side port. And again, the laryngeal mask airway has different sizes, and different sizes suit different patients. And once more, we do not have to memorize this table. And the reason for that is that all the essential information you need is written on the back of any laryngeal mask airway you are going to hold. So for example, on a laryngeal mask, you will find the body weight range that suits this LMA. For example, here it says 30 to 50 kilograms. So you know that this is size 3 and it fits this body weight range. If your patient is heavier or lighter than this, then this LMA doesn't suit him. The second information is the amount of air you need to inject in the elliptical shaped balloon in order to create the seal. Here, for example, it says less than 20 ml. And the final part is this straight line. It goes throughout the shaft, all the way on the back of the shaft. And this is very important because to ensure that your elliptical shaped balloon is actually facing the larynx, you have to position this line aligned either with the nasal septum of the patient or with the upper middle incisors. The insertion technique, actually, the LMA has several insertion techniques. There are so many, but I personally prefer the classical method. The classical method is very simple. You hold it as if you are holding a pen. You are going to write with it. You go blindly into the patient's mouth. While you are doing that, your index finger is going to push backwards so that you slide the elliptical shaped balloon on the hard and soft palate. And you go in as far as your index finger allows you. Once you have gone as far as you can, you leave it and it's in place. You start inflating now the elliptical shaped balloon. I just want to say that when I started, when I was a resident being trained, they used to tell us, keep some air inside the elliptical shaped balloon as you insert to avoid kinking and folding. Now this is out of practice now. Now the recommendation is to completely deflate the elliptical shaped balloon as you go. This is how an LMA looks in place when it is in place. Through the mouth, the elliptical shaped balloon is now masking or facing the larynx, hence the name, laryngeal mask. And when inflated through this side port, creates the seal. However, just remember that this is a seal that is not 100% perfect. It is, as the books describe it, just less than perfect. This means some of the air you are giving from outside is going to go somewhere else other than the larynx. Other than the larynx, there is only one way to go, which is the esophagus here. And when air accumulates in the esophagus and the stomach, this might induce vomiting or regurgitation. And this is the absolute contraindication of the LMA, a full stomach. So to revise quickly, absolute contraindication of the oropharyngeal is intact gag reflex. Of nasopharyngeal is fracture base of skull. Of laryngeal mask airway is a full stomach. And anesthesiologists define a full stomach as the patient has taken a meal within the last 6 hours or a non-transparent drink within the last 2 hours. Non-transparent drinks is something like milk or mango juice. Tea, for example, is transparent, so it's not included. This is a demonstration of the insertion using the classical method, as I told you, which I personally prefer. So I hope you noticed holding it like a pen, going blindly. The index finger is pushing backwards against the hard palate, and you go in as far as you can, you leave it, and then inflate the elliptical shaped balloon. I'll just, out of interest, show you another technique of insertion. It's slightly different, but it has the same basics. Again, it's very essential that the index pushes against the hard palate, and again, this is to avoid the tongue. But here the insertion is being done in a slightly different way.
Seal blue. Place your index finger behind the patient cuff between the juncture of the inflation line and the main tube and grasp the Laryngeal blue securely. Place the tip of the Laryngeal blue patient cuff just behind the patient's upper teeth against the hard palate. Massage some of the lubricating gel contained on the back of the patient cuff against the hard palate before advancing the Laryngeal blue with a definitive force into the patient's airway. Allow the patient cuff and main tube to follow the curvature of the hard and then soft palate along the pharyngeal curve until positive resistance.
Okay, so a slightly different technique, but the same basics. This is a special type of the laryngeal mask airway. We call it the intubating laryngeal mask. It's simply a laryngeal mask that once you insert and make sure that it is directly facing the larynx, you can insert an endotracheal tube inside it and intubate the patient. It's actually a rescue method in difficult intubation. Now we move on, and if we are still not successful, we are going to use a different instrument. I hope you noticed that using our hands, the oropharyngeal, the nasopharyngeal, or even the laryngeal mask airway, none of these devices actually got inside the larynx. They all stopped short of the larynx. The closest one that came to the larynx was the LMA, but none of them got inside the larynx, and so none of them is 100% secure. The only instrument that is 100% secure is this, and this is the endotracheal tube. Its structure, again, we have the universal connector. This is your end. We have, this is the patient's end. This part of the tube goes inside the larynx. We have a balloon here that, when inflated, creates a seal within the trachea, and we inflate this balloon through this side port. The endotracheal tube also has some information written on it, and the most important is this. It's written here ID8. ID8 stands for internal diameter of 8 millimeters. And this is the number you hear anesthesiologists or intensivists all the time talking about. Give me a tube of 7, give me a tube of 6. This is what they are talking about. A tube with an internal diameter of 8 or 6 or 7. And we'll come to the importance of this. Endotracheal tubes come again in different sizes, but also different shapes and different structures. Like this one, for example, this is called armored tube. It simply has a coil of metal within the shaft. And we use this tube in procedures in which we have to have the patient prone, like neurosurgery, for example. Notice that pediatric tubes or small size tubes do not have the cuff. And the reason for that is that the cuff, when inflated in a pediatric patient, sometimes causes injury to the inside of the trachea. So pediatric tubes don't have these cuffs. Now we come to the issue of the size. Now, choosing the size of the endotracheal tube for an adult patient is not a big deal. For an adult male, I would use even sometimes less than 7.5. Sometimes I would start with 7 up to 8. In a female, I would use a slightly smaller tube because of the differences in the body build. Usually a female is slightly built smaller. The point is for the children and the infants, choosing the proper side is essential because, as we said, it sometimes causes injury to the trachea. The most famous formula is this one: 1/3 of the age plus 3. So if you have a child of 3 years old, 1/3 of that is 1 plus 3 is 4. So you choose a tube of 4 millimeters internal diameter. This is a less common formula, 1/4 of the age plus 4, but it sometimes also works. But 1/3 of the age plus 3 is the formal and the most common formula. But actually, choosing the size of the tube is far more important than that. It depends on why you are intubating your patient. So, for example, in the OR, an anesthesiologist is intubating, and he knows that he's going to intubate for the duration of the surgery, then he's going to extubate. So he's looking for the smallest suitable tube. He's going to use the smallest tube that fits the patient. This is to avoid irritation of the trachea post-surgery. However, for us in the ICU, the story is different. We are intubating, and we know that this tube is going to stay for a while, few days, 7 days, 10 days even. So in the ICU, we're looking for the largest suitable tube. And this is to avoid blocking the tube by dried secretions, to facilitate suction, to avoid the ventilator giving alarms of high peak airway pressures. So the size of the tube, your choice, depends on not only the age of the patient, but why you are intubating as well. This is how an endotracheal tube looks when it's in place. As you can see, it has gone inside the larynx. And once the cuff is fully inflated, it creates a seal. Now, nothing can come from outside and enter the trachea and the lungs, and the air or the gas you are giving cannot escape. And this is very characteristic. When you have a patient with a leaking cuff, you have a very characteristic sound of air moving through fluid, something that sounds like this, and forgive me. It sounds exactly like this, and you immediately recognize that this patient has a leak, and the first thing you check is his cuff. Now, inserting the endotracheal tube into the larynx, we said this is the only device that goes actually inside the larynx. So this is what the larynx looks like. These are the two vocal cords. In between them is the space that is called glottic aperture, or the glottis, simply. And beyond that, you have the trachea. You can see the rings here. So this is the space you want to insert the tube in between the vocal cords. But there's only one problem. There is no direct line of sight between your eyes and the vocal cords. And that's why we have to use another device that creates this direct line of sight, that allows you to visualize the vocal cords. And this is the laryngoscope. Now, laryngoscopes come again in different shapes and sizes and in different modifications. However, basically, they are of two types, two main types. a laryngoscope with a curved blade. This is the Macintosh, and a laryngoscope with a straight blade, and this is the Miller. Now, we don't have Miller in our adult ICU. Miller is most commonly used in pediatric patients. So mostly you will see the Macintosh with the curved blade. Technically, there is a very important difference in using the Miller or the Macintosh. And I will talk here about the Macintosh with the curved blade. If you are intubating using a curved blade like a Macintosh, you have to place the tip of your blade exactly in this point. This point anatomically is the common base of the tongue and the epiglottis. It's called the vallicula. And that's why some people say it's actually valliculoscopy, not laryngoscopy. So the reason it is important to insert the blade in the vallicula is that the vallicula has, the epiglottis has a very small ligament here called the hyoepiglottic ligament. And when you press with the tip of the blade on this ligament, it raises the epiglottis upwards, allowing you to see what is beneath it. And what is beneath the epiglottis is the vocal cords. So always remember that you need to insert the blade of a curved laryngoscope in the vallicula. This means that you don't get to see the tongue, but you must be able to see the epiglottis, because this is your line of vision. So you can see the epiglottis, but you cannot see the tongue. We'll see this in a while in a video. Then the laryngoscope underwent some improvements, like the video laryngoscope, or sometimes called glidoscope for simplicity, where instead of the light source, there is a camera that displays on a monitor. And this is also called video-assisted laryngoscope, and it has a very small monitor on top of the handle that displays the field of vision for you. I'm going to show you now an animated video on the 4 steps of using the glidoscope or the video-assisted laryngoscope. Please pay attention to them.
The GlideScope Video Laryngoscope, designed for first-pass success. A 4-step technique to GlideScope video laryngoscopy combines direct vision of the patient with views on the GlideScope video monitor. Start by looking in the mouth to introduce the laryngoscope, at the screen to obtain the best glottic view, back in the mouth to introduce the endotracheal tube, and finally, at the screen to intubate. Begin step 1 with direct vision, looking directly into the patient's mouth. With the patient appropriately positioned and with the GlideScope video laryngoscope in your left hand, introduce the GlideScope into the midline of the oral pharynx. Gently advance the GlideScope until the tip of the laryngoscope is past the posterior portion of the tongue. Unlike conventional laryngoscopy, the GlideScope video laryngoscope is introduced midline. No lateral displacement of the tongue is required. Step 2 is performed while viewing the video monitor the entire time. With the GlideScope inserted, look to the monitor to identify the epiglottis. Then manipulate the scope to obtain the best glottic view. The glottic view is optimized by a combination of advancing or withdrawing the laryngoscope slightly, while increasing the tilt to seat the device in the vallecula or on the posterior surface of the epiglottis to obtain the best glottic view. When the GlideScope video laryngoscope is appropriately positioned, the glottic aperture is centered in the upper third of the video display. This optimal view in the display is achieved using minimal lift force, only 2 to 3 pounds. This provides a wider view and more working space for intubation, while the camera position further reduces the effect on the view from blood and secretions in the airway. The video image of the glottis when using the GlideScope video laryngoscope typically is a Cormack-Lehane Grade 1 or Grade 2 view. The user may be tempted to immediately insert the endotracheal tube and try to navigate it through the glottic aperture while continuously looking at the video screen. However, in step 3, it is very important that you look directly at the patient's open mouth and not at the video monitor, watching the passage of the endotracheal tube to help avoid potential injury to the tonsils or soft palate. The endotracheal tube, which in this case is shaped by a glide-right rigid stylet to complement the angle of the GlideScope video laryngoscope, is inserted under direct vision until the distal tip of the tube is very near the distal tip of the laryngoscope. This relationship is quickly and easily achieved, and only then should you return to looking at the video monitor. In step 4, focus on the video monitor as you advance the endotracheal tube. Returning your eyes to the video monitor gives you a view of the glottic aperture, and near it, the tip of the endotracheal tube. Sometimes a slight withdrawal of the GlideScope is required to reduce the viewing angle and allow the glottis to drop. The tube is then advanced by gradually withdrawing the stylet 5 centimeters as the tube moves forward. Viewing the entire insertion step on the video monitor allows you to quickly and gently rotate or angle the tube using the right hand to redirect as needed. To review, the 4 steps to successful GlideScope video laryngoscopy are: in the mouth, to introduce the laryngoscope; at the screen, to obtain the best glottic view; in the mouth, to introduce the endotracheal tube; and at the screen, to intubate. GlideScope.
So remember the steps: looking at the mouth to introduce the GlideScope, then the screen to get the view of the vocal cords, then back at the mouth while you're inserting the tube to avoid injury, and then back at the screen to intubate. I just wanted to mention something here. The GlideScope is recommended to be held in the left hand. I personally asked the company, and they said, you can use your right hand, but we recommend the left. This is unlike the classical laryngoscope. You have to hold it in the left hand. The other thing is that with a GlideScope, you go with the handle midline. You don't go from right to left as we used to do with the laryngoscope to sweep away or to take away the tongue out of your field of vision. With the GlideScope, you go midline. Now I'm going to show you a video that takes you through the anatomical landmarks that you actually see while you are intubating.
I'm going to place the GlideScope inside the patient. Now obviously you can kind of see there's the patient's nose, lips, right here, the teeth. Now as we go midline, you can see there's the hard palate right over here. Right behind the hard palate is the soft palate. And just below that, as we progress in, there's the uvula and the palatoglossal arches. Behind that, there's the pharynx. So this is the posterior wall of the oral pharynx. And as we go a little bit deeper yet, switch the stylet around, here's the tongue, right there. That's the tongue. Go a little bit deeper, that's the tip of the epiglottis. And in between the base of the tongue and the epiglottis, that space in there is the vallecula. So if you're using a Macintosh blade, you want the Macintosh blade to wind up right inside here. And essentially when you're using the GlideScope, that's roughly the same spot you want the GlideScope tip to reach as well. But remember, unlike a Macintosh blade, with the GlideScope, you're going in midline. With the Macintosh blade, you're going in on the patient's right side and then scooping the tongue out of the way into the patient's left side so you can visualize the glottis. So if we progress a little bit further down yet, there you can really see the epiglottis. There. The blade tips in the vallecula. Now here's the structures of the larynx that we're looking for. Right over here, you'll see the vocal cords, one there, and the space in between here is your glottis. So when you're intubating the patient, what you want the endotracheal tube to do is to pass between the vocal cords when the vocal cords are open, right? And place the endotracheal tube down here in the trachea. So that's the trachea down here. You can kind of see with the intubation head those tracheal rings at the top. So that is the trachea. You don't want the endotracheal tube to go down here because this area here, that is the esophagus. Okay, so once you've got this visualization right over here, what you need to do is grab your endotracheal tube and then insert the endotracheal tube into the patient's airway like so. And you can kind of see where the cuff is against the cords right here. further advance the tube another centimeter to 2 centimeters, and 2 centimeters is ideal, like so. And then when you've got the endotracheal tube in the proper position, of course, remove the stylet while maintaining the same position of the endotracheal tube. At that point in time, your laryngoscope can come out.
So I hope you noticed his emphasis on placing the tip of the curved blade in the vallecula, being able to see the epiglottis, and going midline with a glidoscope. If you were using a classical laryngoscope, go from right to left to take away the tongue from your field of vision. This is a fibro-optic laryngoscope, and we use it, it's similar, very similar to the endoscope, and we use it with difficult intubation. Now we're going to go a little bit into the COVID era, and I want to show you the algorithm that we are adopting for intubation of COVID patients. So this is the algorithm. We'll break it down into pieces. It starts with being called emergency rapid sequence intubation. So why is the intubation of a COVID patient an emergency and rapid sequence? For two reasons. First of all, this is a crashing patient. This is a patient with a very low reserve. So you need to act on emergency basis. The second thing, you want to do it quickly so that you minimize the time you are exposed to the patient and to aerosols generated during the procedure. And the best thing you do is that you plan ahead. It is very important to plan your intubation procedure ahead, prepare everything, make sure everything you're going to need or you might need is ready and available. And the best way to do that is to use checklists. Follow the checklists. Item number 1 present, check, 2 check, 3 check, and so on. And then you start your procedures so that you don't find something missing during the procedure. The other thing I want to emphasize here on PPE check, and this of course means the PPE of the people involved in the procedure. I once read an article, there is no emergencies in a pandemic. What this means is that during a pandemic, don't try to be a hero. Don't try to say, oh, this patient is dying, I want to save his life, and you jump inside the room without protecting yourself. Don't do that. You have to fully protect yourself first. Then you go and help the patient. There is no point in helping one patient and getting 3 personnel infected. So the whole idea of this algorithm is good preparation of the personnel and preparation of the instruments and medication you might need during the intubation. And for that, in KSMC, for example, we arranged a team. The team formation is almost similar all over the world. It's usually 3 persons, and it is recommended that the most senior or the one with the most experience in airway management handles the intubation. And then there are 2 assisting him. One is assisting him with the instruments, and the second is assisting with medication. This is a short clip about the team formation. So I hope you noticed 3 persons only. The most experienced handles the airway. All of them are fully protected with full PPE, and everything is prepared ahead. There are different team formations like this one, for example, but it's very close to ours. Again, the 3 persons, the most senior handles the airway, but then there's a 4th person who is standing outside the room. Notice he is not in PPE. He's not in full PPE, and this is because he's outside the room, and they call him, actually, in this team, they call him the clean person. And his function is that if they need something that they didn't prepare, or they need help, or they need to call somebody, he is the one who's going to run and bring them this help. Now, this video has some very interesting points. It's a little bit lengthy, but I will try to skip it. I want to emphasize on, number 1, when you are intubating the patient and you pre-oxygenate, we do not actively pre-oxygenate. We do not, for example, ambu bag or squeeze the bag. And this is to avoid aerosol generation. It is only passive. You have a high oxygen flow and you just put the mask on the patient's mouth and nose. However, sometimes this is not enough and you must ventilate actively. If you have to do this, please make sure that it is a 2-persons procedure, not 1 person. 1 person is tightly fitting the mask and the 2nd person is ambu bagging. And again, this is to avoid aerosol generation. The second thing is, once you intubate the patient, do not connect to the ventilator or anesthesia machine until you have fully inflated the cuff of the tube. Again, to avoid having spills of saliva or mucus outside, to avoid aerosol generation. If you are transporting the patient, switching from one ventilator to another, make sure that you clamp the tube. You clamp the tube during inspiration before you disconnect, once more to decrease aerosol generation. So I think we can skip this video for the time being. Now, this is very important. Suppose, as we said, you have to bag the ventilation, the patient. You have to do it as 2 persons. 1 person is bagging, the other one is tightly fitting the mask. However, this is not the recommended way to handle the mask. This is the way we learned in BLS. It's called C and E. Notice the thumb and the index are creating a C, and these 3 fingers are creating an E. This is not the recommended way in COVID patients. In COVID patients, this is the recommended way. They call it the V-shaped handle because these 2 fingers are creating a V shape. And the reason for that is that this part of your palm is much stronger, able to create a tighter fit on the patient's mouth and nose and decreases aerosol generation. So remember, please, the V-shaped handling of the mask. Now we'll go back to the algorithm, and we said that the first part of the algorithm is about rapid sequence. So rapid sequence intubation is all about preparation. As you can see, prepare the patient himself, put him in position, make sure that he is well monitored, and even have a supplementary oxygen. Prepare all your equipments, those that you commonly use and those that you think might be needed. Don't waste time during the procedure to go and bring something. Have them all prepared ahead. Be ready to face difficulty, and we'll discuss this in a minute. The other thing is prepare the team themselves. Each member of the team should know his job, should know his or her role, and should do it automatically. So emergency intubation or rapid sequence intubation is all about good preparation. These are, I believe, are beyond our scope. These are the medications that we usually use for rapid sequence intubation. This is a very interesting slide I found in a study. that tells you the timeline of intubation in a rapid sequence. Notice that this is the point 0 where you actually intubate. Notice that they took about 10 minutes preparing from this part, preparation, pre-oxygenation, pre-treatment, and giving medication. They took about 10 minutes. But once you reach point 0 and you are about to intubate, you need to intubate within 45 seconds. And this is how rapid sequence work. If you have a good preparation, then you are going to do the procedure within a very short time. In rapid sequence intubation, to help us remember, there is a lot of P's. They call it the 9 P's. The good plan, the preparation, protecting the cervical spine by positioning the patient, having good pre-oxygenation, and then treatment, medications, I mean, different anesthetics and muscle relaxants, and then placement of the tube, which is intubation, and then post-intubation management. Some people argue that cricoid pressure might be a 10th P, but it has controversy. So now back to our algorithm. We have been talking all about this part, which is good preparation. Now we have done a good preparation. We started the procedure to intubate the patient. If we have a successful first pass, the patient is intubated from the first trial, that's good. But we said that we should be ready to face difficulty. Now, what if our first attempt to intubate the patient fails? Now, we should be ready to face such a problem. Once this happens, once you fail your first attempt, you ask yourself a very important question. Am I still able to ventilate the patient? I couldn't intubate him, but can I still ventilate him? Can I still give him oxygen, be it apneic, as I said, passively, or even face mask ventilation, or with a laryngeal mask or supraglottic device? Can I still ventilate the patient? If your answer to this question is yes, then you can a little bit relax, because you're not losing the patient. Although you cannot intubate him, you can still provide him with oxygen. So you are slightly relaxed here. And then what you do? You are going to move to plan B. Plan B involves either thinking of having a second attempt, but always remember that you are still the same, the patient's still the same. So when you have a second attempt, try to change something. Something must be improved. Like, for example, use a larger blade. If you were using a classical laryngoscope, use a glidoscope. If you were using Macintosh, use Miller. Use a stylet on the tube. So try to modify something so that your second attempt is successful. But if you think that you have done all these things already, and you think that a second attempt is going just to be a waste of time, then immediately consider plan C, because we said that our patient is very fragile and he's already crashing. So think of plan C, which we call the exit option. The exit option means the way out of this critical situation. And this can be either by using a supraglottic device, such as the laryngeal mask airway, or using something that we call cricothyrotomy. And I will show you in a minute what cricothyrotomy is. And the cricothyrotomy recommended approach here is bougie assisted. Okay, let's go back to the beginning of the algorithm when our first attempt failed. And we asked ourselves this question: can we still ventilate the patient? What if your answer to this question is no? Now, this is a very critical and serious situation. This is a situation we called cannot intubate, cannot ventilate. If this lasts for a few seconds, you might lose the patient. You might end up with arrest. So you need to act very fast here and very quickly. You might have a consideration of inserting a supraglottic device, laryngeal mask airway, or having a face mask ventilation. But if you think that this is futile, it's not going to help, it will only be a waste of time, Don't waste time. You don't have time to waste here, so you proceed directly to plan C, only it is called D here, which is, again, the bougie-assisted cricothyrotomy. Now, I'll show you now the bougie-assisted cricothyrotomy. Notice it's done by military personnel because it's an emergency procedure that is usually done in the wartime and in the battlefield.
Cric is indicated. You will start by preparing your equipment. Inflate the bulb with 10 cc's of air, looking for any leaks. Ensure you have your scalpel close by. And prepare your bougie. And then you'll use the head tilt chin lift method to visualize the larynx. From there, with your non-dominant hand, you'll place the larynx in between your thumb and first finger, and then palpate for the cricothyroid membrane. Once you have your site selected, you'll prep with either an alcohol wipe or iodine. And again, stabilizing, this can move quite a bit. So you need to apply a little bit of pressure and make sure that the head is nice and extended. From here, we'll make a vertical incision from the top of the cricothyroid membrane to the bottom. And so, as you apply enough pressure, that skin will naturally fillet open, and then you'll be able to see the cricothyroid membrane. With that, you'll make a horizontal cut, and you'll place your trach hook. And I'm using anterior pressure to visualize the trachea. You'll insert your bougie into the trachea. You'll receive tactile feedback to ensure placement, and you'll be able to feel the tracheal rings as you advance your bougie into the airway. Once the bougie is inserted, you'll remove your trach hook, and then slide the tube down the bougie into the airway. Once your tube is all the way inserted, you go ahead and remove your bougie and inflate your bulb with 10 cc's of air. So once your tube is in place and you've inflated the cuff, suction to ensure that the lumen is clear. You look at the tube, you confirm if you have misting on the tube or bilateral rise and fall of the chest if the patient is unresponsive. If you have someone to help you, you'll secure a BVM and use a stethoscope. You'll listen to the epigastric region as well as visualize bilateral rise and fall of the chest and listen to both lung fields. Once you've confirmed a compliant airway, you'll go ahead and secure the tube to the patient. And once you've secured your cric, you'll reassess.
So with this, I conclude. Again, I stress on no heroism during the COVID pandemic. Please protect yourself. Thank you very much. And I'm ready to take questions if there are any. If there aren't, enjoy your evening.
Thank you, Dr. Walid, for very interesting presentation.
Thank you, you're welcome.
Anyone have a questions?
So I think no more questions, so I'll leave you for your free discussion.
No more question, Dr. Walid. Everybody's thanking you for.
Thank you very much for having me again and again, and you're most welcome. Enjoy your.
You're welcome, Doctor. So, dear delegates, right now we will start the last session of the course. It's an MCQ session. So there will be 40 MCQs for 40 minutes of time. The structure of the MCQs is single best answer. Dr. Ahmed, he will guide you how to participate in this exam. Dr. Ahmed?
Hello, good evening, everyone. Now I post the link of exam in the group. So we have 40 questions. You have to answer it within 40 minutes because after 40 minutes, we will close the exam. So you have to write your name and your hospital Then after 40 minutes, it will be closed. So please answer all the questions. Don't miss any questions. And make sure that after you finish, you can just send me it's done and your name. Just we can double check, because sometimes if you have problem in the internet, it will not be recorded the exam. So just make sure after you finish, inform us it was done in the group and write your name. And thank you. Good luck, everyone.
Thank you, Dr. Ahmed. Thank you to all delegates. Good luck for you and good night.